Okay, can you see my screen? Excellent. So again, I'm reiterating, this is a personal voluntary study group for the CMQ. CMQ refers to the certification in medical quality. There is another certification that's called CMQ OE, which is Certified Manager of Quality, which this is not the purpose. The CMQ is offered by the American Board of Quality. As we said, we'll be alternating the presentations between myself and Rabab, and we're planning that we'll always be doing those sessions every Saturday from 8 to 10. Today might be only 1 hour session where we go through the basics, and then we will start sharing with you what the chapters we're going to go through next, so you can prepare for and start working on it. The CMQ exam is actually happening. This is from the brochure they have. The exam is on the 26th of November of this year, and the venue is in Al Ain University Abu Dhabi branch, which is a computer-based testing center. If you are going to apply for the exam, I'm not sure how many of you are going to apply for the exam, but if you are going to do that, you have to submit your application before the end of this month. Their application is an online system. We will not go through it today, but maybe next time we can log into it and show you how to actually register for the exam. But it would require few steps to be done from your side to be able to register, and they do take quite some time to actually reply to you about your exception and and so on. So by 30th is the deadline to submit the application, and 10th of November is the deadline to submit to finalize your registration and pay to the American Board of Quality. Any questions on this? I think it's very basic and very straightforward. Okay, these are details. I'm gonna send you the brochure about the exam itself. As we said, it's an online application that you fill, and the link is in the brochure itself. You fill it out, you wait for them to confirm, and then as you receive, you start paying. Now, I know there are some of you that are not a Saha employee, but if you are a Saha employee, the cost is 3,050 dirhams. If you are not a Saha employee, it's more. And in both cases, they don't offer you the handbook. The handbook is the one we talked about, or the one I sent you in the group chat. That's the, hold on, I thought I have a picture of it. It's called the Quality, hold on, Medical Quality Management Theory and Practice. This is the book that they will be using. The only difference is that what we have, or what I have as a soft copy is actually the second edition, and what the latest edition published is the third edition. So this is the only difference. And to be very honest, I have not seen the third edition, so I don't know what are the differences between the two things. But I would assume there are too many changes. There are 9 chapters in total. So between now to before the exam, we're gonna go through all of those 9 chapters. Starting from the basic of quality improvement, quality measurement, patient safety, organizational design, medical informatics, economics and finance in the medical quality. I don't know, okay, I repeat that twice. And then utilization management, external quality improvement, accreditation, quality improvement, and then interfaces between quality improvement, law, and medical ethics. These are just the chapters in total. And as we said, we'll try in every meeting to cover 1 or 2, if possible even 3, depending on the details and the interconnectivity between the different chapters. And what we agreed, myself and Rabab, is that we will not be only looking at this book, we will be using other resources and other reading materials that are available when developing those education materials. So going into the first chapter, it's very straightforward chapter. It's only talks about the history of quality improvement, the purpose and the philosophy, some of the tools and methods, and then how do they affect the patient outcome. And I'm sorry, this is going to be sounding very tedious and very basic, so I'm going to try to make it more of a participation-based session, because the purpose is that we all really learn, understand, and go out of this session with some of our, the topics that we discussed intact in our memory. And maybe some of you will be encouraged to actually apply for the exam. So, definitions of quality. There are multiple definitions of quality, but for this book specifically, they have chosen the Institute of Medicine definition, which says it's the degree to which health service increase the likelihood of desired health outcomes and are consistent with current professional knowledge. So this is how they define quality care. Very basic definition is that we only try to do as much as we can for the patients, and the likelihood of positive outcomes or desired required outcomes is going to be coming up. But when anybody is receiving care, when a patient is receiving care, they judge the quality of the care not based on the knowledge or the published consistent with the professional knowledge. They translate it to their own needs and expectations, and then they expect that you as a hospital or healthcare provider is actually meeting their own needs and expectations. Can anyone give me an example of a time when the quality of service, we might think it's, yes, quality service, but the patients think it's not? Any examples? Is my question not very clear? So I said that the recipients of care, which are our patients mainly, they define quality and they judge it based on meeting their own needs and expectations. So are there situations where we as healthcare providers say, yes, we met the quality requirement, and patients would say, no, you did not meet my needs and expectations? Can you think of some examples? You're breaking out. Who is it? I'm sorry, because I'm presenting, I'm not able to see who is speaking. Hold on, yes, please. Sorry, hold on. Again, I'm not sure if it's only me or everyone, but you are really breaking up badly. Rabab, can you confirm? Is it only my issue or? Hold on, can you try again? Okay, in the meantime, Hodan is still trying to find that answer. Can anyone give an example of this? Okay, let me ask the question differently. Was there a time when you went to the hospital and you were not satisfied with their care, but you expect that they would have met their own KPIs? Yes, Rita. No, you're not. You're okay. Mm-hmm. 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 True. So you give a very good example when you said about the waiting time. The KPIs actually allows up to 3 hours of waiting time for patients who are considered, not critical. But if you go to an emergency, you are actually considering yourself to be too critical to wait for 3 hours, right? You would not be happy going there and sitting and waiting for 3 hours. Is that correct? True. And Hodan have written in the chat before she left, she said patients can assume that frequency of utilizing medications and diagnostic tests is a good quality of service. Very true. We have patients who go to come to our hospital and then they say, oh, they didn't give me enough medicines. And then they go to another hospital and that hospital ends up giving them 10 medications for their cases. And that's considered for them a satisfaction that, yes, this hospital is good because they gave me a lot of medications, even though this could be a misuse of, their insurance and prescriptions. So this is what we mean when we say that, um, Mr. Muhammad, are you trying to say something? Okay. So this is what we mean that the care, even though for us increasing the likelihood of desired health outcome is considered as quality care, the patients and the recipients sometimes only evaluated based on their own needs and expectations. And that's why they say now that it's really important to understand the needs and expectation of the patient. And as Sabita was saying, to explain to them what to expect and how often, for example, if you tell them this is for the approximate time of waiting, they decide whether they could wait for that long or they would go anywhere else. Quality improvement in the Agency of Healthcare Research and Quality defines it as doing the right thing at the right time for the right individual, and the aim is to get the best possible results. There are three aspects of quality, and I think we've touched on some of those. There's something called measurable quality. A measurable quality is something that you can, by its name, measure. It's defined, it's objective, and you could, for example, fill a checklist and say, yes, this meets the requirements, or no, this does not meet the requirements, right? If I'm doing a procedure, you could look at the way I wash my hands and say, yes, your washing is right or not. If I'm giving a medications, you could evaluate whether the dose was correct or not. If I'm doing a procedure, you could see whether I have followed all the correct steps from time out, sign on, and all of that or not. So this is measurable quality. It's measurable, it's objective, it's clear, you can count it and you can check it. Appreciative quality, this requires the judgment of a skilled, experienced practitioner and sensitive, caring persons. Like, this is mainly used, for example, in situations when you need people of the same experience to actually evaluate the quality of service that have been offered by someone. And then there is something called the perceptive quality. Perceptive quality is a degree of excellence which is perceived by the recipient or the observer of care rather than the provider. So this is where perceptive is, for example, the patient. The patient will see that, perceives your quality in a certain way based on how they are thinking. So, for example, how this question might show up in one of those quality examinations could be they will tell you, for example, the quality surveyor used a checklist to evaluate the compliance with the medication administration process, the nursing medication administration process. Which one would this be? Is it an appreciative, a perceptive, or a measurable quality? What would you say? It's measurable. There's a check sheet, they're checking and they're making sure that it's done. Okay, there is a patient who complained about the way the service have been rendered to them and said they do not appreciate the nurse's attitude while delivering the service. Which one would this be? Perceptive. Who can give me an example then on an appreciative quality? Any volunteers? Mm, that could be one of them, but there is one that's more, and specifically you, Sabita, should know about. They use it a lot. Peer reviews, definitely. The peer reviews is one way of the appreciative qualities. When you send any document or patient care notes or a complaint or an event, and you send it to colleagues of the same experience in the same specialization to evaluate the care rendered to the patients. That's what you call an appreciative quality. So these are the kind of questions that usually could come on this, like this was done, was it measurable, appreciative, perceptive, and so on. And then they say there is a difference between promised or expected quality versus actual quality or delivered quality, and that's the difference between the measurable and the perceptive quality of care. And sometimes when it's not clear, as we said, like a complaint where the patient says the care was not done as expected, and then there is no specific measure or standard or checklist that I can compare to, that's when I take it to a person who can give me the appreciative quality point of view and tell me, as a principal, as per someone who have the same skills and experience, was this an actual, appropriate care or not, to evaluate the care. So now we go to the bit of boring history. So this is the history of healthcare quality, and they started it in this book mainly referring to a surgeon called Ernest Amory Codman. In 1910, he came up with an idea, or what he called the end result theory. And he said that it's not enough for surgeons' competency to be evaluated to just for them to come do surgery and leave. It's just not just about the number of patients they see. He believed that, or he actually did follow patients that were treated by several surgeons. He's taken some note on those patients on a cards that he used to keep in his pockets. And he used to go and follow those patients to make sure whether the outcome of care that was offered was actually in line with what was expected or not. So then he said that every hospital should follow every patient they treat long enough to determine whether the treatment has been successful, and then to inquire if not, why not, with a view to prevent similar failures. That was the establishments of what we call the quality assurance or the quality control practices within hospitals. You go, you make sure that the patients you treated have had the outcomes you expected them to have, and if not, try to understand why not, to prevent this in the future. Then comes Dinabedian, a very famous for any healthcare quality person. Do you know what's the framework that Dinabedian created? SBO, the structure, process, outcome paradigm. So that was in 1960, where he said that structure, process, outcome, it can be used for assessing quality in healthcare. And this resulted in enhancing patient outcomes. And then they also started considering other areas of care. With Dr. Codman, their idea was that it is the person or the surgeon who's doing the surgery or the person who's providing the treatment who is the reason for that the error or the complications in care that's happening to patients and not meeting the required or desired outcome. But when Donabedian came, he focused on the structure process outcome, and they started looking at things like policy, structural availability of things, organizational changes, patient preferences, and other situations that could lead to other outcomes. And that's when they started measuring things like structural requirements in care, process, and outcome results. And there is another chapter that talks about the results or measuring quality. But can anyone tell me additional examples of what a structure in healthcare could be? What could be a structure in a healthcare organization that affects patient care? Resources like, excellent. So qualification is one, definitely. Technology is another one. Excellent structural points. What else? Any other examples? We already said policy, right? What else? What could you think of that could be a structural, that could impact patients' care? So I'm sorry, I cannot look at at the chat. I am presenting, so I can only see the presentation. So if you can say it out loud or somebody can read out the answers in the chat, that would be good. So yes, the facility, definitely. What else? Training and competency is very excellent. The number of staff that you have in an organization. All of these are part of structural requirements that can set your service or your team either to success or to fail. Okay, what about processes? What could be a process that you could either measure or you could address in order to improve a healthcare quality? Come on, guys, you are all experts. Excellent. So all of the processes depends on what are processes that are touching the patients. Are example of those. You talked about admission, discharge, materials availability and flow. What else? Ryan, process, very important process in healthcare. Medication administration, medication delivery. Okay, then what could be outcomes that can be measured or assessed in healthcare? Definitely morbidity, mortality, yes. Customer satisfaction is an outcome, definitely, yes. Other things, all these outcomes that we measure from patients, improvement, heart failure, readmission, length of stay, all of those are considered an outcome of care that we offer. Now, why am I spending so much time on this? I don't want us to just, sometimes we just read those words, we know them, we heard them 1,000 times, but we don't really wait and sit and try to think through each one of those words. So, and the exam, whether it was the CBHQ or the CMQ, actually the time I took the CMQ, they were very focused on names. Who is the person who did this? Who was the person who came with the structure process outcome? Who's the one who invented the end result theory? And it was very kind of a lot of straightforward and historical kind of memorizing questions. But I heard later that it was more like, it became more like the CBHQ questions, where they would give you long sentences and then you are really supposed to memorize or remember a certain sentence or a certain statement and so on. So I'm trying to focus on those words that are really considered kind of key in those points and try to emphasize them. And by the way, I kept a session 1 and a session 2 because, again, as I said, this is a personal account. So when it becomes like 60 minutes, I will have the meeting is going to be closed. So you're all expected to join the other link that I provided you with. Okay. So this is Donabedian, that he moved the paradigm of quality from just focusing on the person to focusing on the more wider aspects of structures, policies, organization changes, and so on. Then came Walter Sheward, and he talked about a concept of the goal should not be inspection and specifications only, but we should try to minimize variations in the processes and to focus on the customer needs. So by minimizing variations, he set up what we call currently the quality control processes, where there is an expected upper level and a lower level, and then all of our process needs to be maintained within those upper and lower levels to ensure that we are delivering quality service. Both Shewart and Demings actually came from factory or industrial quality points, and that was then later used widely in healthcare. So quality control was initiated from there. And then came Edward Deming, who was a student actually of Sheward, and he created what's called the 14 points of quality. And then he also extended Donabedian model. And at his time, the quality management was redefined that it's not just technical clinical exercise, but also an issue of culture and values, psychological climate, and leadership. So see, now they started looking more at the patients in a holistic view rather than just focusing on the aspects of the physicians or the healthcare providers and so on, and that the culture was important point there. Later on came the teachings of Crosby, Demings, and Duran, and all of them brought to attention a lot of things that relates to system design, process control, involving the whole workforce. That's when the whole concept of the total quality management came to life. So this is just very quick history. As I told you, in the exam I attended, there were a lot of questions about, yes, who created the 14 points of quality management? That was Edward Demings. Yeah. Quality control started by, and minimizing variation started with and then it's Walter Sheward. So that's the exam I attended. But it could be, you could, for example, not see any of those examples. It's good knowledge to know how the quality evolved in healthcare from those individuals. During the 1980s and the 1990s, the regulators started doing inspections, and specifically in the US, that's where insurance companies and payers started looking at quality assurances and started understanding more about the hospital's performance. And then this led to the establishments also of accreditation bodies like the Joint Commissions, the National Quality Committee of Quality Assurance, and then the National Quality Forum. All of that started doing a lot of data collections and assessment of quality across the nation. And this is healthcare quality specifically that we're talking about. In 1998, there were two members who developed or defined the problems of healthcare. And they say that in healthcare, we have three main problems: overuse, underuse, and misuse. They started it with medicine, and then they went on to actually all aspects of healthcare, and they called it the healthcare quality problems. So, overuse. Who can give me an example of overuse in a healthcare facility? Unnecessary ordering of investigations, correct. Sorry. What about underuse? Any example about could be? But what could be, like, for example, I don't know for you. For me, you're clear. I can't hear any echo. Rabab, can any of you hear any echo? From Sabita specifically or from that's weird. I don't know if this is related to any audio setting, but to me, you are all clear. I can hear you okay. Okay, I really don't know what's the problem here. Okay. Um, but those two, Chassin and Galvin, they started talking about overuse, underuse, and misuse of in medicine. So can anybody tell me what could be an underuse of medicine? So that's the overuse for investigation. But what could be an underuse? Could be. So the same example Isel gave about the overuse of investigations. There could be an underuse of investigations, right? A patient who needs an ultrasound, but he was not ordered any ultrasounds, for example. A patient who needs some, for example, okay, so here it's actually what it means is that it's underused. It's available, but it's not used. It's not that it's not available. That's another issue we'll talk about when we talk about accessibility and other things. But here is that you have the thing available, but you are underusing. So if we talk, for example, in medications, overuse could be the overuse of antibiotics. And that's why they started the stewardship. And these two were actually two of the champions of stewardship programs. There could be an overuse of narcotics, and then you end up having addicted patients and so on. Underuse could be that the medicine is available and the patient needs it, but then they don't prescribe it for whatever purpose or for whatever reason. That could be misdiagnosis, could be, whatever it is. So it is available, but it's underused. It is not used to the benefit of the patients. So what could be a misuse? And not only medicine, could be medicines or other wrong prescriptions, wrong, wrong treatment. Yep, we talked about it. So the antibiotics, if you overuse it, and that's why now there is an antibiotic stewardship processes to stop it. But now what about misuse? Could be a misuse of resources. It could be a misuse of resources. A complication is a complication, whether it was caused by impractical use of or surgical procedure or whatever. But what could be a misuse? Could be in medications, could be in treatment, could be in supplies. So let me go here. Maybe those definitions are going to help you more. Overuse, here it says the potential for harm from a health service exceeds the possible benefits. And that is if you give more medications than the patient needs. We gave examples about antibiotics. We gave examples about narcotics. We gave examples about other ways of overusing things. Underuse, it's something, a health service that would have produced favorable outcomes that was not provided. So it could be either a diagnosis, a medication, a supplies, or whatever. Misuse could be a preventable complication that occurs with an appropriate service. So if they had done everything well and then they had complications, but there is also the concept of misusing equipments or resources for the purpose that it was not intended for. Let me give you an example. Sometimes you would find that some people would use a sterile gauze to give patients a bath. Is that a misuse? Do you think it can be a misuse? Yeah. So it's using something for not for the purpose it was intended to. So you would find that there are some equipments or resources that are available in some units. I remember in one of the hospitals there was actually an equipment. It might have been a portable ultrasound machine that was available in the organization, but it was never used. Under which heading it will come? Is it an overuse, underuse, or misuse? Underuse. So you have the resources, it's available. You even have the expertise who could use it, but it's an underuse. Misuse, as we said, is using things not for their intended purposes. And this was first published or done back in 1998. In 2000, then the IOM published To Err is Human. IOM is the Institute of Medicine, and they published what's called To Err is Human, Building a Safer Healthcare System. And this is the title of the book or the report that they have created. Who can tell us about? I think every one of you knows what is this To Err is Human. Who can tell us why it was initially developed or published? Let me go to the screen. Anyone knows? There was a book published by the Institute of Medicine back in 2000. It's titled To Err is Human. Anyone knows why it was published? Yes, no? Yep. It's not. Yes. Mm, true. That's true. Excellent answer. So when back in 1999, they studied the number of medical errors that happens in hospitals, and they found out that there is around one what was it 75,000 back at that time medical errors that could have been easily preventable in healthcare. And from then on, the number kept tripling and quadrupling. But the point was that they found out that there were a lot of errors that were caused by healthcare systems and hospital staff, and the, for preventable reasons. And that's why they produced what's called To Err is Human, because they studied the nature of all of those errors, and they found that it was related to preventable things like communications, collaborations between people, processes that were not clarified, and so on. We will talk about this in more details when we talk about the patient safety, but that was a major shift in the way healthcare is done, and that there are human errors and there are organizational factors that actually lead to these errors that needs to be addressed and taken care of. We talked about the misuse and so on. After that, there was something called the healthcare system design that talked about what are the elements that are required as part of the healthcare design and delivery. I think we've got less than 10 minutes, so maybe at 9:15 we will close this session and then we will join the other link to continue with the rest of the session. But they talked that in healthcare, when designing healthcare systems, what needs to be addressed is that the healthcare should be safe, effective, patient-centered, timely, and equitable. what is what could be a safe healthcare delivery? Excellent. So keeping patients safe, they come to our hospitals to be treated and not to be injured. So a safe, a reliable healthcare is what they require. What is an effective healthcare system? We are running out of time, so if somebody can give me an idea or a definition of what could be an effective healthcare system. Anyone? Evidence-based practice, definitely, but what's the word? What's the meaning of the word effective? Could be, but what does it mean? When you say I received an effective treatment, what does it mean? Correct manner, it's there, but that's not exactly what I'm looking for those. Right, resources and all of that is good, but what if I take a pain medicine and I say the pain medicine was effective? What does it mean? Okay, alleviated the pain, the patient feels better. Welcome, Menadine. Yes, sure, that's fine. Excellent. So, an effective care is a care that produces the intended results. I took this for pain treatment, then it's treating my pain. I took this for to be able to move better, then it's making me able to move better, and so on. Uh, what's the next one? Patient centered, very straightforward, as we said. The focus more is on patients and the patient's needs, and the care needs to revolve around patients, where we involve them in making decisions and so on. Timely. What does timely mean? Reduce the waste, avoid delay. Excellent. Excellent. So um, if I give you care fast, does this mean it was timely? Exactly. So giving the care at the time it's needed. Sometimes it means you need fast care, like if you go to the emergency and you are in a critical situation. Sometimes it means on time care. And last is equitable. Straightforward. Equitable is that the equity between all the patients we're treating shall be treated the same. Let's stop here for this session and look into the other link. And I think we will take another maybe 30 minutes or 45 minutes to complete the session. See you in the other link. We will go to that. There's another slide that talks about that. Sure. Thank you. Let's log into the other thing. Thank you. See you. Hello, everyone. Just give me a moment to admit everyone. Let's give others time to join again. Okay, I think we have the majority. And I'm going to admit anyone who joins us as a new person. Give me a minute to share my screen. Okay, can you all hear me okay? Okay. We move on to the next, which is the what they call the purpose and the philosophy of quality management. And in healthcare, uh, they've talked about three concepts here. First was the accountability, the concept of accountability. And here it talks about the accountability of the use of clinical and physical resources in the care of patients. So accountability also refers to avoiding the common mistakes in healthcare quality, which are the overuse, misuse, and underuse. And the second philosophy was continuously develop and improve services that provided to the patients. That's the basic and the core of quality in any organization. And the third option is also implementing or the clinical outcomes improvement as defined by the patients and the healthcare system. So these are what in the medical quality book is titled as a philosophy of quality management in healthcare. Very straightforward and understand. So here, Menadine, you were asking me about the effectiveness, efficacy, and the others. Now we come to what's called the dimensions of quality. And in the dimensions of quality, they talk about there are around 11 concepts here. So the first one is appropriateness. Who can define the word what does it mean to when we say appropriateness in healthcare? Anyone? Correct. Excellent. So all of you kept saying right, right when I was talking, asking you about effectiveness. Appropriateness is provide the right, appropriate, available, or applicable to use for the patients. It should be relevant, as Rawab said, to the individual clinical needs. I'm not coming to you with a heart disease and then you are treating my sore throat, for example. Okay. The second point is availability. What does availability mean in a healthcare? And one of you already touched on this subject when they talked about availability. Excellent. Availability, accessibility. And I think you, Adina, were the best person who said about sorry, when healthcare resource or tool is not available to the patients or is not accessible because they're living in a rural area. So availability means making sure that the healthcare is accessible and obtainable by all members or all people who need care from us. Okay. One of you answered previously that one of the structural requirements we have in hospitals is competency. What does competency mean? Skills. Skills to do what? Definitely. So competency refers to the ability to provide the care with a satisfied performance that adheres with organizational standards. So you could insert an NG tube anyway, or you could insert it according to your hospital policy, or you could insert it according, and that's why we do what is called competency assessments or competency evaluations for our staff to make sure they're able to always comply with the organizational standards that we've set in place. What does it mean to have continuity in healthcare? It could be continuous. We keep them in the hospital, we don't allow them to go out. So coordination of healthcare services, definitely, and somebody said follow up, which is true. So think of a patient who was discharged from your hospital, making sure that you provide continuous service to them through ensuring follow up, ensuring they have coordinated services, even with the healthcare services outside. Someone else is unmuted and wanted to say something else. Definitely, they're transferring patients to different levels of care. So they were in a hospital and then now they're moving to more of a home care setting or to a long-term organization. All of that is part of the continuity of care. And as it says, he's the coordination of healthcare needs over time. So we make sure that the patient continues to receive the care that they require over time. Effectiveness, we talked about it, and effectiveness here means providing the care in the correct manner to achieve the current outcomes, and which mainly leads to positive results of care delivery. So if I take medicine and I would say the medicine is effective, it means it delivered the results I needed. If I have gone for a procedure and the procedure resulted in what I needed, then it is effective. Okay, what about efficacy, Manadine? Maybe you want to tell us. What did you, which was talking the other one? It's like, is it? No, it's like efficacy. Efficiency. Efficiency. Okay, fine. طيب, do you want to take a go and try to give an example of what could be efficacy? Efficacy. Maybe uh, reaching the optimum result. There's efficacy and effectiveness are close, but there is only one word, I think, in efficacy that makes it different. Where do you see the word efficacy mentioned mainly? Lab, it could be also medications, it could be procedures. But sometimes they will be advertising one medicine and they will tell you it has an efficacy of 99% on something, okay, eradicating the disease or of killing microorganisms or something. Okay, so efficacy, and I will tell you the keyword here is literature. So it's the capacity of the treatment to produce the desired outcome, which is similar to effectiveness. But the only thing here is it's as shown in the literature or research. So efficacy is mainly, you could see it as part of the medication pamphlets or as part of the research saying that this medicine have proven efficacy of this much percentage or whatever. So it's the same as effectiveness. The only difference is that the efficacy is linked to the word literature. So if there are multiple choice questions and you're worried, not sure which one is it effectiveness or efficacy, then if it says literature or research, then it's definitely efficacy. Efficiency is the one you asked about. Did you ask because you know the answer, or did you ask because you wanted to know the answer? Waste of resources, true. And somebody also said the same before. The efficiency is the relationship between the outcomes and the resources. So I could be getting the outcome by maybe taking one type of medications, or I could be getting the same outcome by taking multiple types of medications. Efficiency is as long as you're making sure that you are efficient in the resources usage and you still produce the desired results. That's when we say efficiency. They always, and this is mainly CPHQ, they always play with these three words. They would give you a scenario and then they will tell you this is efficacy, efficiency, or effectiveness. And you would need to know the difference between three. Effectiveness, straightforward, there is an outcome, a positive outcome. Efficacy, it is related to literature or research. Efficiency is always related to the resource and reducing wastage. Okay, another dimension is the prevention or the early detection. And as the name says, is that only straightforward that the degree to which interventions promote health and prevent illness. So all about, for example, vaccinations, early management of diseases, early detections and screening situations that happens to make sure that there is an early detection of the disease. Next is respect and caring. Respect and caring is being respectful and caring to the people we're dealing with, sensitivity to the individual needs and expectations, and this include all elements from gender to culture to religion to all aspects of the person that we should be sensitive to and care. Safety. What does safety mean in a hospital? And I think we talked about that. Minimizing the risks of adverse outcomes. So making sure that the patients stay safe throughout their stay. We're not making them fall. We're not making them creating for them complications. We're not putting them at risk of fire or at risk for any other things that might affect their safety while they are in the organization. And timeliness, again, similar to what we talked about, is the most beneficial time or perception of promptness. And as we said, this depends on when do you need the care the most. If you need it to be fast, then fast care is timely care. If you need it to be timely on specific intervals, then following those intervals is also the timeliness of care. We're moving now from, we talked about a bit of definitions, history, and then some of the dimensions and quality care. Here we talk about the improving or implementing a quality improvement model. And I have a typo here. The first was the sources of quality improvement projects. Can anyone tell me how can you identify the need for a quality improvement method? How do we identify incidents or gaps in the service? Definitely. What else? Definitely. If you have a high volume service, then you want to make sure that it's always correct. And this is one of the things that you would consider when selecting or when prioritizing the different solutions. But what else? What could be the resources or the sources of identifying the need for quality improvement? Complaints, feedback, incidents, definitely. KPIs, data, definitely. What else? Audits, definitely. So let's imagine a unit that doesn't have complaints, does not have audit findings, they're always 100% and no complaints, no incidents. How could they identify quality improvement? Or do you think there is no need for quality improvement? Process review, definitely. I could be looking at my processing and going saying, well, maybe we could do something to make it less complicated, less painful, less, waste. It could be from the suggestions or the ideas that the people have. It could be, so there are multiple and different ways of how you can identify or look at sources of quality improvement methodologies or projects. Benchmarking, def, amazing, amazing, definitely. When you don't have many issues, and this is what we come across, some departments will tell you, I don't have problems, I'm okay. I don't need a quality improvement project. But there's always a chance for improvement. You could benchmark with best in class. You could look at how the best hospital in the world is doing and try to do a project to reach their level. You could be saying, I do this procedure in 5 minutes, but what if I can do it in less time? Innovation. You could have innovative stuff that could come up with new ways of doing things totally. Assessments, definitely. This would fall under similar examples of the audits, the inspections, KPIs, data collection. The assessment is one of the ways that you collect data. And usually when you are assessing, you have a certain set of questions or frameworks that you're looking for to make sure that, yes, I am following it or not. So these are all sources of identifying the need for QI projects. Now, let's say we have a unit that has a lot of patient complaints, they have a lot of KPI issues, they have a lot of audit findings, and they are drowning in a huge number of quality improvement projects that they could start. How could they prioritize or choose a certain quality improvement project? Whatever affects patient safety. Okay. Who else has another point? Okay. Yep. So this graph here is showing some of the prioritization matrices that we use in healthcare, or even in anywhere when you are trying to, you have a lot of priorities and you're trying to come up with the one that's really important and beneficial to your people. So you would look at the impact, and this is where you say for those, for example, whatever that has a patient impact would ideally come on the high impact end. But that's not the only thing. There could be the urgency. So the impact, I might be having patients-related issues, but they're not urgent. They could wait. I could have a complaints or patient feedback, but I could wait. But then I might have something that's really urgent that needs to be handled. I'm having an urgent, for example, request from the government, or I'm waiting for an audit from DOH, or I'm getting I need resources to be available for certain structural requirement, or procedure or room changes that I need to do. So you would always do this. You would calculate the impact and the urgency of each and every one of those projects, and then you can put them into these 4 quadrants. Preferably, these 2 needs to be addressed immediately. Here it means it's urgent and it has high impact. And here it says it still has high impact, but it's not urgent. These are the 2 things that you will start prioritizing. Things that are urgent but low impact, maybe you even decide not to do them. If it doesn't have impact on me or my patients or my staff, why would I even invest time and effort? And not urgent, low impact is even more reason not to consider them and to remove them from the list of your priorities. So this is one of the ways that you could decide on the choosing a quality improvement project. One of the other things that Menadine started listing is things that you would look at high volume. Is this really high volume service in my department? Is it affecting most of my patients? Is this a high risk procedure I'm doing? It might be only one patient in a year that needs this procedure, but it's really risky that if this procedure goes wrong, the patient could die. Could it be high, what could be like affecting the patient experience? You would also look at that and considering, because it's going to affect all of the patient experiences that you have. So these are some of the prioritization processes or matrices that people use when deciding on a quality improvement project or program. Then they started talking about the tools for quality improvement, and I will go through this very quickly. They talked first about process mapping, and then they said process mapping could be the very basic step in any quality improvement project. And then here they have listed what they call the 7-step model for process improvement. So you identify the potential target or of opportunity. So this is what we said. We look at complaints, we look at incidents, we look at other sources of data, audits, and so on. We synthesize information about the optimal practice, what we are doing now, or what could be the best practices, and then what's the current practice. We understand where are we standing now, and then identify reasons for discrepancy between the current practice and the optimal practice. Why are we not doing the best practice? Why are we just doing whatever we're doing today, and how we can improvement? Develop a strategy for practice improvement, assess effectiveness and cost effectiveness of the practice, and then determine whether this practice improvement strategy should be implemented and how it can be improved. This is what they call the 7-step model for process improvement. And as we said, it always starts with looking at your current practices. So part of the process mapping, sometimes you do flow charts and just general straightforward flow charts where you could set the steps, and you could even categorize it by the different departments or the different groups that are part of this process, and you look at how you do all of those procedures. Now, one of the ways you could look at flow charts for improvement is that you look at your decision points and you decide, is this really needed, or maybe we are over engineering a simple process. And then you look at all the processes you have. If you have 1,000 boxes here, like more than 10 boxes, you might start asking yourself, why is this procedure so complicated, and can I make it easier to be followed and easier to be understood? Cause and effect fishbone diagram. I know this is abrupt, but Sabita, maybe I will ask you to tell us a little bit more because you use it more than I have ever used it in my life. Sabita? Mm, Thank you very much, Sabita. So as Sabita explained, it's she's the expert. She uses it almost on a daily basis. But when we say the fish bone, this would be the fish head, and then these would be the bones that comes out of it. And usually this refers to what is the outcome, what happened. So in the case that Sabita gave, that the patient had an adverse reaction, this would be the case. And then you will start looking at this. For the image I used, they've used the machine, method, material, measurement, people, environment, for example. There's some others that use the 7 P's: process, people, planet. I don't know exactly. So there are different ways, and as Sabita said, for healthcare and for central events or for JCI, there are other specific tools. The only purpose is that you are looking at the root causes, and then you are understanding. It helps you to structure the kind of questions that you are asking. What's the environmental reasons for this to happen? What are the people related elements? So in the case of the sentinel event or the adverse reaction to the patient, it could be the people did not have enough training, they did not have appropriate competency, maybe they were not even the right specialty to see patients, and so on. So very straightforward. It's a cause and effect diagram, fishbone diagram, and sometimes it's called Ishikawa diagram. That's correct, Sabita? I'm not making up things. Ishikawa. So again, you could see it in the exam by any of the three names. Brainstorming and affinity diagram. Brainstorming is just the concept of us sitting together, thinking of all the different reasons why would something happen. But what's an affinity diagram? An affinity diagram is when you collect all of the brainstormed ideas and then you put them into specific groups. So, for example, here they were looking at the way they run team meetings, and then they started looking at what could be the problems here. So, a couple of them wrote issues that were all categorized under timing. Another group wrote issues that were under focus and attendees. So, you just collect certain number of ideas, and then you initially start brainstorming. What could be the reason? Why are we having? What are the problems that are happening? And you start thinking. When you do brainstorming, the main key is that there is no wrong answer. Everyone is respected and all answers are considered. And then you start putting them into the affinity diagram to see what are the major groups that it goes under and then evaluate its improvement or reasons of happening. Then we have what we call a Pareto chart. Actually, I'll come back to it. I wanted to rearrange the slides, but I forgot. There's something called a histogram. Histogram is what you see in the picture. It's just an indication of a certain number of items and how many times it has been repeated. So this was, for example, the sale price of something, of properties, and then what are the number of properties that were sold and what are the cost or the sale price for them from 50 to 100. So usually when you do a histogram, it's usually giving you a range of data in between the different measurements. And then you could see easily what is the most used or the most used. For example, here, what's the most used price for those properties, for example. It's very straightforward and very simple tool that's used within usually representing data and quality. Bar chart usually indicates again, similar to the histogram, certain percentage or data. The only thing is that the base is not usually connected to the following one, and it represents single points of data that are collected and looked at. So, for example, here it's looking at the percentage of length of hospital stay amongst all patients. So, 35% of the patients stay for less than 24 hours, 29% stay between 24 to 48 hours, and 20% stay between 48 and 72 hours, and 15.4% stay more than 72 hours. This is definitely not data from our hospital or any of the hospitals I know, because patients usually stay more in the hospital, and this is one of the KPIs that are being collected across the organization. So we have the bar chart. Now, when we look at the Pareto chart, it's a bar chart, but the only difference is that it's first of all arranged by the number of, from the highest to the lowest, and then and then you look at what are the vital few things that if you resolve, you can get rid of the majority of your issues. So let's say we are looking at the reasons why the patients are not satisfied. And here we say that the biggest reason is waiting time, followed by attitude, followed by food, for example, followed by clothing, respect by the individuals, and availability of the specialties they're looking for, yada, yada, yada. So you look at all the reasons, and then you find that the highest one is the waiting time. What you would do, the Pareto chart is called the 80-20 principle. So you look at what are those three things that make up the 80% of your score. And that's what you call the vital few. The vital few are the things that if I solve the issue with the waiting time, if I solve the issue with the respect, if I solve the issue with the meals, I'll be able to have 80% of my patients satisfied. So it's a commonly used system for categorizing actions. Like, for example, remember when we were talking about that unit that had a lot of quality issues? They could create this Pareto chart, look at the different reasons or different issues they're having and how many times those issues are happening, and how many percentage, for example, of their patients it's affecting, and then try to address the vital few that could be closing the 20% of the problems that could help in closing 80% of the issue. I hope that's clear. And then they talk about statistical control charts, and control charts here talk about, as we said, there is an upper value, upper control limit, a lower control limit, and then you look at your data points and you make sure that it's part of the or around the average output that's expected. So, sorry. So this is a simple statistical control chart. And when I was talking about the history, I talked about the person who first started with the quality control concept. Anybody remembers who was that? Short. So Schubert was the person who talked about the quality control and the concept of quality control. And then I think in one of the other sessions, we will talk about data, and we'll talk about the different data points and what does it mean when it looks like this, and what does it mean when it has different shapes as well. I will end my session today here. This talks about the quality improvement methodologies, and we will talk about them. We'll start with them next session, inshallah. And this talks about mainly, specifically, the BDSA, Six Sigma, and then Lean management. So, and here is a simple comparison table that's available in the chapter 1 of the book I sent you. They're talking here about the differences in the process steps of BDSA. Is that circular step? So it's plan, do, study, act. For Six Sigma, it's design, measure, analyze, improve, and control. And for Lean, they only focus on looking at the process or the flow of information or processes within the organization, and then eliminating those non-value adding steps and reducing defects and cycle time. Lean is mainly focusing on making things shorter, more standardized, up to the point, to offer the service. The BDSA focuses in the improvement on the rapid cycles of improvements. So a lot of times it's used for piloting or for small-scale improvement projects. Six Sigma focuses on eliminating defects and customer-centric, and Six Sigma is focuses also on the statistical analysis, reducing the number of defects to less than 3.4 in a million opportunities. And Lean focuses on enhancing efficiency, eliminating of non-value adding activities, and reducing cycle times. The ideal use for the BDSA, as we said, it's for a target project chosen for improvement. Time and resources are limited. Six Sigma is for target project. Time resources are available, and the project consists of activity that's repeated with high frequency. So as we said, like manufacturing, like something that you do all the time. Admission process is an ideal one, for example, or registration process is an ideal one because it touches all the patients and it's repeated with a high frequency in hospitals. Lean is mainly focusing on process efficiencies and can be clearly defined and has a lot of non-value adding points that can be removed. Support tools that are used along with those are for BDSA, environment for testing, prototyping. As we said, it can be used in a lot of pilots. For Six Sigma, statistical process control and charts. And for Lean, they use it in addition to something called value stream mapping, value analysis, and Kaizen. We will be talking about those methodologies and those aspects of quality improvement in the next session, inshallah. As we said, it's going to be weekly sessions where we talk about the different chapters and try to go through them, hopefully in a quicker pace than I was doing today. Again, today was mainly the introduction going through the ask, the exam, and then the first chapter. I will end the presentation here and open it to you for discussions. What's your feedback on the session? Do you think it was too quick, too slow, could be improved? I want to hear from you before we conclude for today. Anyone, any volunteer that will speak up? Thank you very much. Thank you. Mhm, mhm. That's true. That's true. Thank you very much for your point. And again, focusing on the exam question kind of things is that they will ask you, an organization was collecting this type of data and they wanted to understand what is the most, important process they need to start with for improvement. Which chart should they use? And they sometimes they will give you either a chart shape or they will tell you what this chart represents for you to be able to connect it to the correct answer. So looking at multiple charts and identifying the differences is a really good way of doing this. One of the things myself and Rebab discussed was also looking at possible questions from the exams. We don't have specific CMQ related questions. If anyone of you has it and can share, that would be great. But we have other questions that relate to the CBHQ, and again, they're all talking about the same thing, which is exam questions, exam terminologies, and how to answer them. So we'll definitely try to share more of those in the beginning of next session. Expect an exam, so we'll try to go through some test questions, inshallah. No volunteers. The exam is going to be for everyone. No, it was actually the first time was 5 years ago, and since then they offered it 3 times, and this will be the fourth. Yeah, that's true. And it's offered usually like once it doesn't have a specific frequency. Like if you want to go for exams like the Certified Professional Healthcare Quality and the others, they have a specific test centers and they have specific frequency. Whenever you want, you can go for them. But this specific exam is a collaboration between SAHA, the American Board of Quality, and the organizing entity for this exam, and they don't come very often. So it's a good way to actually be part of that and use this opportunity for going to the exam. You are very welcome. For those, thank you. Am I going too slow for you guys? I know the expertise in quality is different. Is it too slow? Is it okay? Should we continue with the same pace? Should I give more examples? Yeah, thank you very much. Okay. So thank you everyone for you joining and for your participation. Thank you as well. Thank you for being here on a weekend. So see you next week, inshallah. Yeah. Thank you everyone. See you.